Hey, future respiratory therapists. So, if you've seen any of my videos, you know I've done some disease breakdowns in the past, pleural effusion, maybe asthma, maybe a couple of other ones. And Jay comes to me and asks me to do a breakdown for COPD. So that's what I'm going to do today. Now, I'm going to show you this, and you're actually going to see another video of this very, very soon, where I'm going to show you my study methods for learning disease processes that can transcend over into other classes also. You just have to figure out how to break it down simplistically. Okay, so this is my simplistic breakdown of COPD. I currently spend close to 3 hours teaching COPD in the classroom. Once you have the classroom knowledge, then you can break it down very simply, and it doesn't have to be 3 hours to explain. So I'm going to attempt to do it here in less than 10 minutes. We'll see if we can get it done. Now, we know our platform here is COPD. So if I'm going to break this down, I'm going to start with the centerpiece of COPD, and I'm going to put some words or some terms up here that I'm going to use as platforms to jump off of to take me down the road to talk about other things. So the first thing I'm going to do is put BB and PP. Now, when I say BB and PP, in my mind, I understand that that stands for blue bloater and pink puffer in regards to COPD. Now, this is important because this tells you the two disease processes that make up chronic obstructive pulmonary disease, okay? Not the 5C babes that make up all of the obstructive lung diseases, but when you talk about specifically about somebody has a diagnosis of COPD, that means that they present with fundamental elements that support the diagnosis of emphysema and the diagnosis of chronic bronchitis, and together those make COPD. So blue bloater refers to our chronic bronchitic component, and pink puffer refers to our emphysematic component. Okay, so that's where I go with that. Now from there, I understand my anatomical alterations. Okay, my chronic bronchitis patients are going to present with airway inflammation, which is going to cause excessive bronchial secretions. That's one of my anatomical alterations. The inflammation can also lead to bronchospasm. So I have that with chronic bronchitis. And then with emphysema, my anatomical alteration is distal airway and alveolar weakening, which leads to the destruction of the distal components of the pulmonary system, being the terminal bronchioles and the alveoli. Okay, they destruct, they lose their rigidity, which leads to air trapping, which leads to hyperinflation and the breakdown of our normal pulmonary tissues and structures. Okay, so this is my first platform. This starts me off with putting me in the right ballpark of what disease processes are I'm talking about on a completely another level from just saying COPD. Okay, so you have to do that. Now from here, I'm going to go into etiology. Okay, and I'm going to say number one, smoking. We know that chronic bronchitis and emphysema together make COPD, and the primary two causes of chronic bronchitis and emphysema is smoking. Okay? Everybody knows it. Okay? It's not a secret anymore. It's 2019. Everybody knows that this is the side effect of smoking if sustained at a high enough level for long enough time. Okay? So, number one is smoking. Now, underneath that, I'm going to put 20 pack years. Because when you say smoking, you say, oh my gosh, I smoked this cigarette when I was 19. Am I going to get COPD? No. So we need to understand that 20 pack years is the level to where somebody becomes at an enhanced level for developing a pulmonary disease secondary to the smoking, most likely COPD. 20 pack years. How do we calculate 20 pack years, or how do we get pack years? We multiply packs per day smoked by how many years you've been smoking it. So if you've been smoking 22 packs a day for 10 years, you're at the 20-year mark, the 20 pack year mark. If you smoke 1 pack a day, wait a sec, what'd I say? Oh yeah, 2 packs a day for 10 years, 20 pack years. If you smoke 1 pack a day for 20 years, you're at the 20 pack year mark. Okay? That's just where it is. That's what it is. And these are the things that come to mind when I think about COPD, thinking about what diseases am I talking about and what causes that disease, which is the etiology. Now, there's other things such as recurring infections that can cause chronic bronchitis. There's indoor and outdoor pollution. There's occupational hazards that or lead to the inhalation of noxious fumes that can lead to chronic bronchitis and emphysema. There's antitrypsin alpha-1 deficiency that can lead to emphysema. We understand that all of that falls under etiology, but in my mind, I'm going smoking number 1 because that is the number 1 cause. Okay? Now, after we talk about etiology, I want to talk about my patient assessment component. Okay? So here, I'm just going to say patient assessment, which is physical assessment, and we're going to break down all the key findings that you'll probably find on your physical assessment of your COPD patient. So I always start at the head. Okay? You're probably going to see pursed lip breathing. Now, from here, I'm going to say, why are they pursed lip breathing? Because they need more time to exhale to empty their lungs at a greater level. They air trap naturally because of the disease process, because they've smoked, and now they have to pursed lip breathe to exhale all of this gas, which will then allow them to take in a deeper tidal volume. Okay, so pursed lip breathing is a big one. Okay, if they are severely cyanotic, you may see central cyanosis. That's CC, central cyanosis. If they're severely cyanotic, or if they're severely hypoxemic, okay, you may see central cyanosis. Now, as we move from the head down to the neck region, okay, you're not going to see a tracheal deviation because it's a bilateral lung disease, so it won't pull or push the trachea to one side or the other. But you might see JVD, okay? So I'm going to put JVD right here, and this is the result of cor pulmonale. Cor pulmonale happens because the persistent chronic hypoxemia leads to a state of persistent pulmonary vasoconstriction, which puts an increased workload on the right side of the heart. Fluid backs up. It increases the right side of the heart, which leads to cor pulmonale. Fluid backs up, and the first place you see it back up to is JVD. Now, can it back up to cause pedal edema? Yes. Okay, we'll talk about that in a second. Now, the next thing, when we get to our extremities, you're going to see possible digital clubbing. Digital clubbing is the result of chronic hypoxemia. Okay? Now, you might also have pedal edema if the cor pulmonale is causing a big enough backup of fluid that goes to cause JVD, and then secondary to JVD is extremity pooling or interstitial fluid at the extremities due to the right side of the heart fluid backup. You might have pedal edema also, okay? Not an always persistent every single time finding, but possible when you think of physiology and the way the blood flow through the heart works and what pulmonary vasoconstriction does to the right side of the heart, which backs fluid up all the way back to the systemic vessels, okay? So, what else are we going to find when we do our physical assessment? We're probably going to see a barrel chest. This is where the chest enlarges greater front to back than it does side to side, and this is due to the persistent air trapping that happens over time, okay? So, those are your key findings associated with your physical assessment. Now, when you go from physical assessment, you can also include percussion. When we tap on a patient's chest, we should hear a hyper resonant note. When we do palpation, I know you can't read this, but I'm trying. When we do palpation, you're going to have a decreased fremitus. Why? Why a hyper resonant note? And why decreased fremitus? Because of the bilateral air trapping. It will cause a less dense area beneath the thoracic cavity. When you tap on it, it will be hyperresonant. When you fill them, breathe, and say 99, you'll have a decrease in fremitus. You'll also have a decrease in expansion because of the air trapping reduces the amount of expansion that the chest wall is able to do because the lungs are already full with air. And so they can't take in a nice, good tidal volume like the normal patient does or the healthy patient does. Okay? When you auscultate, I'm not going to put this on a board, but underneath physical assessment, when you auscultate, you could hear diminished, you may hear crackles, and you may hear expiratory wheezes. Okay? Just know that's what you're getting on auscultation. Now, that's a lot to talk about in physical assessment, but that's what comes in when you talk about COPD. Okay? Now, the other thing we need to talk about when we talk about COPD is our chest x-ray findings, and there's 4 key findings. You're going to have hyperlucency. Okay? This is due to the extra amount of air that's in the lungs, so it creates a more of a dark field instead of a normal a normal film that's kind of grayish with feathering for the lung tissues. The extra air that's trapped will lead to a hyperlucent film. You will also see a depressed diaphragm, and that is because of the air trapping. The air trapping actually pushes the diaphragm down. Now, when the diaphragm gets pushed down, so does the heart, and it becomes long and skinny. It almost looks like a bicycle seat, okay? Especially in your emphysomatics, it turns more into a bicycle seat looking appearance, okay? And then the last one is that you'll have increased intercostal markings. So increased intercostal markings. Why? Because the lungs are no longer normal, they are hyperinflated, and it causes the ribs to get further apart. Okay, so those are your key chest x-ray findings when you're talking about COPD, chronic bronchitis, and emphysema. Now, when we talk about treatment, you just need to go back to your anatomical alterations. If you have bronchospasm, you treat it with a beta-2 agonist, such as albuterol. Okay? If they need more of a maintenance medication, depending on the severity of the disease, then you may add a parasympatholytic. That's a big old word. And now we're talking about adding Atrovent, so you may could do Duaneb along with your albuterol. Or you could do Atrovent along with your albuterol, which would be Duaneb. Or you could just do an albuterol SVN and then give a Spiriva DPI to administer the medication. Now they're also going to probably get inhaled corticosteroids to reduce the amount of inflammation that's happening within the lungs. Okay? And then if the secretions are bad enough, they may need some type of secretion clearance therapy. So either CPT or some type of PEP therapy or something to help them remove the secretions associated with the chronic bronchitis component of COPD. Okay? Now, on top of these therapies that we're going to provide for our patient, okay, you also need to talk to them about smoking cessation, because while they cannot reverse the effects, they can prevent further damage. So reverse the effects is impossible, but preventing further damage, it can be done. So stop smoking. Also, pulmonary rehab will teach them how to live with the disease process they have. And then finally, you need to talk about O2 therapy, which is going to help reduce the signs and symptoms associated with the chronic hypoxemia. Now, in this case, you're not trying to fix the hypoxemia because it's chronic. It's not acute hypoxemia. We fix acute hypoxemia, but with our COPDers, we just treat the signs and symptoms, meaning the tachypnea and the tachycardia that comes along with the hypoxemia and the dyspnea. We want to take that away. So we want to take them from a baseline level of 50 millimeters of mercury when you're talking about PaO2 up to 60. They're still mildly hypoxemic, but that difference in oxygenation levels will help reduce the signs and symptoms associated with it. The last thing I need to talk about, and which I already know I'm over 10 minutes, I'm almost to 15 now, is this, ABG. you need to understand chronic vent failure. Okay? So your COPDer, definitely your end-stage COPDer, all right, you need to be able to recognize that they live at a higher level of CO2. So their pH may be 7.36. Their arterial CO2 may be 60. And their bicarb may be 32, 34. And their O2 may be 60. You need to understand that this is okay for this patient. This is chronic ventilatory failure. This patient lives at a CO2 of 60. We know that because their pH is within the normal range. You do not put this COPDer on a mechanical ventilator. You simply don't. Because this person is walking around Walmart or Target or wherever right now. This is where they live. Okay? So do not put this person on a mechanical ventilator. Now, if they come in looking like this, CO2 is 90, and the pH is 719, now this is no longer chronic vent failure. This is going to be acute vent failure. Acute vent failure superimposed on chronic vent failure. We know it's acute vent failure because we're acidotic on our pH. And we're acidotic because our CO2 is elevated. We know it's superimposed on chronic vent failure because our bicarb tells us that I live at a state of chronic vent failure. My bicarb is up because we always live with a high CO2, but we don't live with this high of a CO2. So when you're taking care of COPDers and you understand this entire process, the biggest thing you need to understand is you do not treat CO2. You treat pH. You put this person on a ventilator and you blow their CO2 down until their pH comes back up to 7.35. And then you stop because that's where they live. Okay? Do not try to fix their O2 here. You don't want them to be 90. You're good with 60. Let it stay right there. Okay? So this patient, you just need to get their CO2 down until their pH is on the acidotic side of normal, and you will be good. Hey, I ran way over time. I thought I could do it in 10 minutes, but some things you just can't do. So I appreciate you asking me this question, Jay. I hope this helps. If you have any other questions for it, be sure and send them to me. If you haven't pressed the subscribe button yet, please do so now, and also like this video. Thanks for watching, guys.